So now we are seeing about the cystic kidney diseases also. Let's move on to the renal tumors. So renal tumors are very important in the exam point of view. So let's start with the first tumor, which is the Wilm's tumor. So Wilm's tumor, we all know it is going to be the most common primary renal tumor of childhood. So usually they present within an age group of less than 5 years. So 2 to 5 years is the age group wherein Wilm's tumor is presented. So the mutation commonly seen here will be involving the WT1 and WT2 genes. So both of these genes are going to be present on chromosome 11, but the location will be chromosome 11p13 for WT1 and chromosome 11p15 for WT2. Okay, so they ask for these locations also, so please do remember it. So WT1 and WT2 is mutated, and sometimes you can see Wilm's tumor associated with certain syndromes. So what are the syndromes? Weger syndrome, Dennis-Drass syndrome, and Beckwith-Wiedemann syndrome. So Weger syndrome, you have Wilm's tumor, then aniridia along with that genitourinary abnormalities. And here and also in Dennis-Drass syndrome, both of these conditions, it is the WT1 gene which is going to be affected. Okay, for this one and this one, WT1 gene is going to be mutated. While in Beckwith-Wiedemann syndrome, it is the WT2 gene which is going to be affected. So in Beckwith-Wiedemann syndrome, we have usually hemihypertrophy. So large tongue will be there and the organs will all undergo organomegaly. So this kind of a hemihypertrophy is seen in Beckwith-Wiedemann syndrome. So classically, how do these Wilm's tumor present with? Usually the classical history given will be by the mother. So the mother while feeding, she would have felt a abdominal mass. So other than usually in renal tumors, they present with hematuria, but in Wilm's tumor, it is the abdominal mass presentation which is quite common. Okay. And then the precursors for Wilm's tumor will be certain nephrogenic rests. So these are nothing but embryogenic rests only. So they can undergo this malignant transformation and form this Wilm's tumor. So nephrogenic rest, if you are able to see it on microscopy, you will have to keep the patient under follow-up because there is going to be an increased risk of developing Wilm's tumor in the contralateral kidney as well. Okay, so the documenting the presence of this nephrogenic rests is quite important. And we all know Wilm's tumor is going to be a triphasic tumor. So triphasic tumor, what are the three components of Wilm's tumor? First component will be a blastemal component. So the blastemal part here is all this dark blue colored cells. So it appears quite dark blue, right? So these are primitive cells. So they'll appear like blasts. So very small round blue cell tumor. So these are small round blue cell tumor which has this blastemal appearance, primitive cells. And then next component will be the abortive tubules or glomerulus. So these structures we see here, no? So these are trying to form the tubules or glomerulus. So here it is forming the tubules actually. So they are trying to form the tubules, but they don't have a proper lumen. So these are called as abortive tubules, and this represents the epithelial component of the tumor. Then comes the third component, which is going to be the intervening this mesenchymal spindle cell tumor. So these spindle cells which are seen here, no, so that represents the stromal component. So this is the mesenchymal part of the tumor. So the triphasic components will be blastemal, mesenchymal, and the epithelial components. And whenever you see any anaplasia in a Wilm's tumor, it means that it has a very bad prognosis because it is going to be associated with a P53 mutation. So wherever P53 mutation is there, we lose the main control of the genome itself. So P53 mutation is going to have a poor prognosis and these patients will be chemo resistant. So next we'll see about renal cell carcinomas. So the major risk factors of renal cell carcinomas will be genetic causes and other factors. So under genetic factors, RCCs are usually have a syndromic association. So what are the syndromes associated with RCC? We'll see that. So the first syndrome will be VHL syndrome, which is von Hippel-Lindau syndrome. So we all know VHL syndrome, the gene which is deleted here will be chromosome 3p. So VHL gene which is present on chromosome 3p is going to be deleted, and here they can have multiple tumors. In renal system, we are going to have clear cell RCCs. Usually bilateral clear cell RCCs will be there. Apart from that, VHL syndrome can also present with other CNS tumors and also retinal angiomas, cerebellar hemangioblastomas. These kind of vessel related tumors will be there. Then we have hereditary papillary renal cell carcinoma syndrome. So HPRCC syndrome. Here the gene mutated will be MET. MET gene is present on chromosome 7, and here it is going to result in, as the name suggests, papillary RCC. Another syndrome associated with papillary RCC will be HLRCC syndrome, which is hereditary leiomyomatosis with RCC. So basically, the patient is going to have multiple leiomyomata throughout the body, and other than that, they are going to have papillary RCCs as well. And here the gene mutated will be a fumarate hydratase. So fumarate hydratase, we know it is an enzyme involved in the Krebs cycle. So that gene is going to be mutated and it can result in a papillary RCC. Suppose there is a sporadic kind of mutation, for papillary RCC, then it will be involving the trisomy 717 and loss of Y chromosome. So genetics of papillary RCC, you will have to remember this also: trisomy 717, loss of Y chromosome, fumarate hydratase, and met chromosome 7 mutation. So this is also there for papillary RCC. Then we'll move on to the third type of RCC, which is chromophobe RCC. This is going to be associated with the Birt-Hogg-Dube syndrome. So Birt-Hogg-Dube, so the gene will be BHD, the short form of the syndrome. So BHD gene, which is encoding a protein called as folliculin. So that is going to be associated with chromophobe RCC, and as such, sporadic cases of chromophobe RCC will be having multiple loss of chromosomes. So it will result in a hypodiploidy. Even though there is hypodiploidy, chromophobe RCCs are going to have a very excellent prognosis. And lastly, we have childhood RCC. Even in children, renal cell carcinomas can arise, and these are usually associated with translocations involving the XP chromosome. So XP translocations involving the TFE3 gene are usually associated with childhood RCC. Since these are newer concepts, these can be asked as MCQs. So under non-genetic factors for risk factors for RCC, the most important one will be the tobacco. Tobacco is a very common risk factor for RCC. Other than that, dialysis. So chronic dialysis can lead to some cystic kidney disease. So acquired cystic kidney disease can be seen, which can then progress on to a papillary RCC again. So dialysis is a risk factor for papillary RCC. Other than that, we have sickle cell anemia, which is again a risk factor for the medullary RCC. So these are again common MCQs. Then we'll see about the individual RCCs now. So clear cell RCC, it is going to be the most common kind of RCC, and again, be it sporadic or VHL syndromic associated, the chromosome which is going to be deleted here will be chromosome 3p involving the VHL gene. So VHL gene, chromosome 3p. Other than that also, if you don't have 3p deletion, you can have some translocations again involving the chromosome 3 only. So translocation 36, 38 and 311 can be seen. And clear cell RCCs usually arise from the proximal convoluted tubule. Then on immunohistochemistry, if you see, there are very few tumors which express a epithelial marker and a mesenchymal marker simultaneously. So CK is a cytokeratin. So cytokeratin is an epithelial marker, while vimentin is a mesenchymal marker. So very few tumors express this co-positivity of CK and vimentin, and clear cell RCC is one such tumor wherein this co-positivity of vimentin and CK is seen. Okay, and clear cell RCCs are known for hematogenous spread through the renal vein. So through the renal vein, they can even reach up to the right atrium. Then these are also associated with some paraneoplastic syndromes, the most common one of which will be the hypercalcemia. So other than that, we can also have polycythemia because of erythropoietin secretion, hypertension, and Stauffer syndrome. So Stauffer syndrome is nothing but there is going to be liver dysfunction in these patients, but without metastasis. So liver dysfunction without metastasis to the liver is called as Stauffer syndrome. So microscopically, if you see, clear cell RCCs are going to form these nests of clear cells. So all of these are nests of clear cells which are going to be separated by these very thin fibrovascular septae. So these thin vessels will be separating these nests, and the cells of these, as the name suggests, will be having a clear cytoplasm. So if you see, all of this is all empty looking, right? So clear cytoplasm, because these clear cells are actually composed of both glycogen and lipid. So composition of this clear cell RCC will be both glycogen and lipid. Since it contains glycogen, you can confirm it by applying a periodic acid shift stain. So PAS stain will be positive. And for lipid, if you put a frozen section with oil redo stain, that will come positive. Okay, these are special stains for glycogen and lipid. Next, we'll see about papillary RCC. Papillary RCC, again I mentioned, it was one of the commonest tumors associated with dialysis. So dialysis related to acquired cystic kidney disease can transform onto papillary RCC. Again, genetics we saw, two syndromic associations, which was HPRCC and HLRCC, involving MET gene mutation and fumarate hydrate mutation. So in sporadic cases, we saw it was related with trisomy 717 and loss of Y chromosome. And then here, papillary RCCs are known for having bilaterality and also multifocality. So bilateral and multifocality is common in papillary RCCs, and the origin of papillary RCCs will be from the distal convoluted tubules. On immunohistochemistry, papillary RCCs will be positive for CK7, which is cytokeratin 7, and other than that, AMACAR positive. So AMACAR is a protein which we usually see in a prostate cancer. So AMACAR comes positive in prostate cancers as well as in papillary RCC. So this is the microscopic image of a papillary RCC. So what does a papillae mean? Papillae, it means it's a finger-like projection, and a true papillae will have a central fibrovascular core. So this fibrovascular core is, if you see this image, this RBCs are lying, no? So all these are the fibrovascular cores surrounded by these papillae. So these papillae are all lined by cuboidal cells, and inside the core also you see certain foamy macrophages. All these cells are foamy macrophages. So this is the classical image we see in a papillary RCC. So already I had mentioned, any kind of papillary tumors, we have a samoma body formation. Why also I mentioned. So here again you can see the presence of samoma bodies. Third type of RCC we'll see is chromophobe RCC, and here the genetics was extreme hypodiploidy. So multiple chromosome loss will be there, but still here it's going to have an excellent prognosis, and the origin of these tumors will be from the collecting duct. Okay, and here syndromic association was Birt-Hogg-Dube syndrome, wherein folliculin gene was mutated. The microscopic image of chromophobe RCC is quite important because it has been asked as potential MCQs many times. Exact image, this image has also been asked. So how does this chromophobe RCCs look like? They have a plant cell-like morphology. That is, they have very defined cell borders. So in this, if you see, they have very defined prominent cell borders. So this kind of morphology is called as plant cell-like morphology. And then along with that, you also see perinuclear halo. So around the nucleus, you see this fried egg kind of an appearance. So this is a perinuclear halo. And how is the nucleus? The nucleus is all appearing shrunken and like a raisin. So like a coilocytic change it appears. So the cells look like coilocytes, right? So don't call it as coilocytes. I'm just telling it for remembering. So raisinoid kind of a nucleus will be seen in chromophobe RCC. So plant cell like appearance along with the perinuclear halo and raisinoid nucleus is the classical image of a chromophobe RCC, and here it can be stained with Hales colloidal ion stain. So Hales colloidal ion stain will stain it blue in color. So the chromophobe cells are stained blue, and this exact image was asked in previous year questions. So next, medullary RCC. So nothing very important about it. So the origin of the cells will be in the medulla. So obviously from the collecting duct cells it is going to arise. And the most important thing is it is associated with sickle cell disease. So sickle cell anemia, this can have this complication of medullary RCC. Then Bellini duct or collecting duct RCC. One thing is it is going to have a worse prognosis. Then XP translocation RCC involving the TFE3 gene is common in childhood. So childhood RCC is we see in XP11 translocation.